morning, everyone. My name is Dr. Abhirama Chandra Gabbita. I'm a consultant neurosurgeon at AIG Hospitals, Hyderabad. I did my Neuro-Oncology fellowship at SGPGI Lucknow, and I did my Skull Base fellowship at Weill Cornell, New York University. I did an observership at Stanford University. My basic interests are at Neuro-Oncology and open and endoscopic skull base. When you see brain tumors in white light, what happens is at some point of time, the differentiation between the normal tissue and tumor tissue becomes little bit difficult. Whereas if you compare it with a fluorescence guided surgery, the tumor tissue is delineated from normal tissue because of fluorescence. There is a recent paper from Tumor et al. In 2024 and also way back in 2006 saying that fluorescence guided surgery through FIALA in high grade gliomas, that is grade 3 and grade 4 gliomas, the extent of resection is almost 70% as compared to 30% in normal white light surgery. When we give FIALA to the patients and resect tumor, the chance of giving gross total resection or near total resection is higher with FIALA than white light surgery. Fluorescence guided surgery, the factors that usually influence the choice of dye are type of tumor, whether it is a low grade tumor or high grade tumor, and also blood brain barrier permeability, whether the blood brain barrier around the tumor has been disrupted or not, and also the depth of penetration. These three factors usually influence the fluorescence guided resection and the choice of dyes. For high-grade gliomas and glioblastomas, anaplastic gliomas and glioblastoma multiforme, the choice of drug is FIALA because it's a prodrug which converts into protoporphyrin 9 and it specifically accumulates only in the tumor tissue. Chance of giving a gross total resection is more with FIALA. But if you compare to sodium fluorescent, the mild disadvantage of FIALA is the depth of penetration is not that great. If you take a low grade glioma, the blood-brain barrier might be intact, so FIALA might not be that specific. Whereas if you take sodium fluorescent for low-grade gliomas, it can show mild fluorescence or negative fluorescence in low-grade gliomas, and also for in-depth tumors, it might be useful. The other dyes like indocyanine and green, these can be used for meningiomas, but not for gliomas, not for intraxial tumors. My experience with FIALA is I have used it for two cases. One case I want to discuss in a standing manner because this patient actually presented with a right-handed weakness. So initially in the emergency room, it was thought as a transient ischemic attack or stroke and patient was thrombolized. Just diffusion weighted image was done because it was thought as stroke and it was thrombolized. Later again within 1 month, patient presented again with the same weakness. So repeat imaging showed lesion with mild contrast enhancement. So as there is contrast enhancement, we thought this is a high grade lesion. That's why I counseled the patient for FIALA resection because this tumor was present on the parietal cortex and also it was going onto the motor cortex at the thumb area. So I've done multimodality resection in this patient where I have done a connectomics guided surgery for preoperative mapping where we can see the sensory motor neural network and also we can see the fibers from thumb area going into the corticospinal tract. By this, what we have come to know is the thumb fibers have shifted little anteriorly. He has developed weakness only because of the edema. Intraoperatively, I did a small 2 centimeters craniotomy, bang on the lesion. Cog leads were placed to see the position of the central sulcus, phase reversal, and to see where the motor cortex is. All the parietal cortex tumor has been resected. Then I have used FIALA to resect the tumor that is going on to the motor cortex because The ultimate goal of a resection is to give gross total resection so that progression-free survival and outcome scales will be good. Tumor that is on motor cortex was seen nicely as a pinkish red color, whereas the normal brain tissue was purple color. I have stimulated the tumor that is on the thumb motor cortex. There was negative mapping, hence I went ahead and resected it with Fiala. If not Fiala, I would have definitely missed this part of tumor, and also tumor that was in a little depth, and the patient would have come back after maybe 3-4 months again with a sizable lesion. It's been almost 8 months. Patient received radiotherapy and concurrent temozolomide chemotherapy. There is no recurrence till now. Yeah, the other case was also a left temporal glioma. The tumor has been resected, and small bits of tumor that was in depth was resected using Fiala. He is also in follow-up for the past 6 months. There's no recurrence as of now. Yes, definitely. Protoporphyrin in the tumor cells is seen as a fluorescence with a specific blue light that is around 410 to 460 nanometers. If you ask me whether you prefer loops or a filter to the microscope blue light filter, definitely yes. But currently, the existing microscopes, the blue light filter is very costly. There is a company who is doing the loops, but it is also becoming a little costly. I would definitely prefer to have a blue light filter for the microscope or even the loop. Microscope is better because what happens with Fiala is when you want to save small perforators, especially at the insula, you cannot differentiate them in fluorescent. So we have to shift back to conventional white light, slowly preserve them, and again restart the blue light and start resecting the tumor. So this becomes very easy with microscope having a blue light filter. Communication to the patient and attenders is very important, and also written consent is very important. So I explain them saying that on imaging it seems to be a high grade tumor. Progression free survival and outcome scales depends upon extent of resection, and these two will be dependent on how much tumor we remove. This can be achieved well with the Fiala fluorescent than sodium fluorescent or normal white light. So what I tell them is the complications with Fiala are well known. The only possibilities are photosensitivity. Patient might have photosensitivity reaction. So I'll tell them that for first 24 to 48 hours, avoid light exposure. So we usually keep them in dim lights even in the hospital and in the ICU post-operatively. And we tell them that some patients might have mild elevation of liver enzymes which are not little concerning, which usually comes back to normalcy after a week. These are the only specific two complications I'll tell with the Fiala. And we'll ask the patients if they have any porphyrias. When porphyrias are present, we usually don't give Fiala. Whereas coming to the benefits, I tell them, as I stated previously, the RESEC trial and also the Tumor et al. Trial says that the extent of resection with the Fiala is very significant compared to white light surgery or sodium fluorescence. And the benefit, if you weigh the benefit versus risk, the benefit is far more than the risk. So this is how I counsel my patients in opting for Fiala surgery. The misconceptions regarding brain surgery is a lot of patients have myths that if you get a brain surgery, you're going to die or you're going to develop a permanent deficit. But I think it is slowly fading off because now functional surgery, onco-functional balance is being a routine practice. There are a lot of pre-operative, intraoperative, post-operative adjuncts that help in bringing a safe maximal resection into the play. It's like a la carte surgery. You can do preoperative mapping with connectomics or transmagnetic stimulation. You can do intraoperative stimulation with direct cortical stimulation, subcortical stimulation. With Fiala fluorescent, we can extend the extent of resection. And one more thing I wanted to add was even recent trials are coming saying that when you give Fiala, the uptake in the tumor cells, the uptake will be on the tumor cells. Post-operatively, you can give photodynamic therapy and sonodynamic therapy to enhance the cytotoxicity of tumor cells. This is also one important point for Fiala section. So overall, if you ask me about the myths, they're slowly fading off. There is a lot of significant functional recovery for brain lesions.